Respected Chairman, dear colleagues and friends, I am Dr.GJPurohit from India, and my topic is lower end of the radius, benign junction tumor, and Bloc excision and reconstruction, study of 9 cases. We all know distal end of the radius is the most common site for BGCT of the long bones. Also, it is a benign aggressive bone tumor of obscure origin presenting in 3rd and 4th decade of life. This particular lower end of the radius site has further distinction of having more aggressive behavior of GCT with higher chances of recurrences and malignant transformation. 1% of these metastatize mostly to the lungs. Number of treatment options are available. The site-specific treatment include curative bone grafting, where the recurrence rate for primary treatment of GCT is relatively high, and in view of this, the aggressive lesions, the ideal treatment is en bloc excision and reconstruction with non-vascularized or vascularized fibular graft. We have routinely used ipsilateral non-vascularized fibular autograft for reconstructing distal radius and present here experience with this procedure. The indications of en bloc excision are extensive aggressive lesion grade 2 and grade 3 recurrent tumors of the after previous curator, extensive bone destruction where the articular surface cannot be salvaged. A total of 11 cases of GCT distal radius operated en bloc resection with non-vascularized fibular autograft reconstruction of the distal radius at our institute during the period from 2002 to 2017, and we were able to follow 9 of these cases, and they are classified according to radiological grading. 9 patients, the aims, objective and material, the clinical examination, local any metastasis, soft tissue extension, pathological fracture, investigation, laboratory and radiological, all workup was done. After the FNAC or biopsy confirmation, the planning preoperatively was done. The measure the graft length from the radiological investigation. Nowadays, role of AI and 3D will improvise this technique. Fixation plan using the plate or even for the K-wire for the temporary stabilization. And 3D simulation will be helpful in near future. Bone grafting, autogenous iliac crest at the host graft junction, and in cases of the radiocarpal fusion, there also we can do bone graft for enhancing the fusion. We all know the surgical technique and block resection, fibular graft and plate fixation along with the iliac graft, evaluate the functional and radiological outcome, assess the complication, determine the role of wrist arthroplasty or fusion as per the patient requirement and position. Proper explanation, evaluation, consent taken with risk consent for various complications we all know. Approach, either molar or dorsal approach depending upon the tumor extension or biopsy scar. Wide resection of the distal radius, typically 2, 3, even more proximal to the tumor boundary should be done. Now should be preserved. The proximal fibula anatomically mimics the distal radius shape, and therefore it is most ideal for replacing the radius. In cases of arthrodesis, radiocarpal fusion is done, fibular graft is fused to carpus. The fixation using long locking compression plate is ideal, spanning from radius to the metacarpal. The advantages being high stability, pain-free, strong grip strength. The disadvantage being total loss of the wrist movement. Reconstruction using arthroplasty, where the fibula head serves as the new articular surface of the radius. Ligamentous reconstruction is done. The advantage being preserves the functional range of motion, but the disadvantage being potential point joint instability and degenerative changes over the time. The proximal junction is fixation is done using plate between the fibular graft and the blood host radius. Distal junction, in case of fixation, either screw fixation or long locking plate is advisable. In arthroplasty cases, capsular repair with the K-wire stabilization is necessary, and bone grafting in all cases is done. This is in short brief technique under general anesthesia, under tourniquet, proper approach, biopsies are excised, radial, extracorporeal excision and Bloc is done, and 10 centimeter average bone dissection is done. Tumor bed is treated with anti-tumoral agents. After hemostasis, ipsilateral fibular graft is harvested, which was placed at the site of the radius along with the proper plate fixation. Radiocarpal ligament is repaired. Iliac crest grafting is done routinely. And we routinely obtain 3 to 5 mm extra length of the fibula to cover for compression of the radiofibular junction and error in taking the measurements. Postoperative protocol immobilization in 3 months. We routinely do intermittent mobilization of the elbow when patient come for the dressing or change of plaster, KY removal at the end of the 3 months, and full activity at the end of 1 year. At 3 months, plain radiograph of forearm were repeated to see the union, recurrence of the tumor or graft-related complication. After first year, follow-up was at 3 monthly intervals for 1 year and 6 monthly interval in 3 years. Thereafter, patients were evaluated annually to the latest follow-up. Mean follow-up was 3.3 years. Union at fibuloradial junction was in 33 weeks in arthroplasty cases, whereas in fusion cases it was earlier. Lead strength was 71% of the normal. Range of movement was 162 degree. Patient rated wrist examination in the pain subscale and functional scale was fusion. In cases of the fusion it was 70, whereas in case of arthroplasty it was 80. This is the first case. We have 23 years osteolytic expansion lesion with pathological fracture, treated by POP somewhere else for fracture. On radiological investigation, it was found to be extensive soft tissue extension along with the aggressive osteolytic lesion, and articular involvement was there with cortical thinning and cortical fracture. Radiocarpal pattern was lost, and this was aggressive local confirmed by biopsy. This is the peroperative photograph of the excision, fibular harvesting, and the plating was done. At that time, we were using semi-tubular plate. Nowadays, the compression BCT platings are being used. This was a case of fusion, follow-up at 2 years. This was histological slides to be confirmed. At 2 years follow-up, the fusion and the were united. And this was at the end of the 3 years, and the implant was removed with the age of confinement. Second case, extensive resection, 2.5 years follow-up with arthroplasty cases. The third case, chronic addiction, tobacco. Patient had skin problem, superficial infection which was healed after removal of the implant. Again, extensive lesion involving articular cartilage, wide excision, fibular grafting, and plating was done, which was removed. Drug DRUJ stabilization by K-wire. Another case, very extensive lesion with articular involvement, same treatment, with arthroplasty was done. This is the last case. Again, the excision and plating was done. Functional outcomes in this series of 9 patients, union rates, grip strength and MSTS scores 91.38% were consistently high with no tumor recurrence. There was no case of non-union. Grip strength was 70% in arthroplasty, 82% in fusion cases. Reliable union in all the cases. Non-vascularized fibula also acts as an effective procedure. It is cosmetically acceptable in all patients except one dead scar of the superficial infection. Subluxation in 3 cases acceptable. No complaint except grip weakness. And 4 excellent, 3 good, and 2 satisfactory. There was no complication, no non-union except some cases of joint subluxation. Donor site mobility only in 1 case. No case. Local recurrence minimized by achieving wide oncological margins. So there was no recurrence. Infection only 1 case having chronic addiction, which was healed by removal of the implant. No nerve complications. These are the references by Gill, SS, and Bloc, Excision and autologous fibular reconstruction for aggressive giant cell tumor study. Long-term effectiveness of the vascular flap in radiological reconstruction, and distal radius reconstruction with vascularized fibular autograft is equally and better helpful. Long-term follow-up of non-vascularized fibular autograft for the distal reconstruction is advisable. So these are the comparative study table of various Gill and vascularized fibula, long-term fibular graft, and our series 9 cases, 3.5 years follow-up, no recurrence, no mortality, and no even fracture. All cases united with good functional outcome. So the role of AI 3D robotics in near future. Radiomics will help in early diagnosis, grading, predicts the recurrence and aggressiveness, decision support, and curettage versus en bloc excision, what should be decided? 3D technology will help in CT-based 3D tumor mapping, imaging, and patient-specific cutting guides will be available with accurate margins. Custom processes or graft planning will be helpful with this. Robotics and navigation will help with high precision tumor resection. Will accurately customize the implant for the patient with the graft replacement, and it will be real-time intraoperative guidance, precision, personalization, and predictability the result in the near future with this technology. This is comparison MSTS course across the studies. This is the grip strength. The ours are 70% as compared to other series. Overall functional outcome comparison MSTS score was 90% in our cases. Summary, conclusion, learning points. En bloc wide excision is the gold standard and preferred for aggressive GCT of the distal radius, provides reliable oncological clearance to eliminate recurrence risk. Non-vascularized fibular graft is a reliable, technically simple, cost-effective reconstruction option. Excellent structural support is provided by the fibular graft. Radiocarpal fusion should be considered in cases with instability or extreme ligamentous disruption. Demonstrated superior stability and grip strength and early union compared to arthroplasty in unstable wrist. Fusion is preferred for high demand patients needing stability. Arthroplasty is considered for patients requiring mobility. Autogenous iliac bone graft enhances the union at the fibuloradial junction. So regular post-operative imaging is essential to detect the early complications such as non-union or subluxation of the recurrence. Functional outcomes depend significantly on meticulous rehabilitation and protected mobilization. The technique ensures predictable union, acceptable grip strength, and durable long-term stability. Live fibular graft is indicated in very large defect, poor local biology, previously failed grafts, smoker or bone poor healing, or if the early union is essential and microvascular expertise is available, and we have no experience of this technique. Thank you all. I have nothing to declare. You are all welcome to Ahmedabad, India for IOCON 2026 academic feast in the first week of December, India. And I have nothing to declare except many thanks to organizers of the 10th Annual Congress of Orthopedics for organizing such an excellent feast, and also thank you all for attending my session.
Do you notice there's an anatomic difference between the fibular heads, which use ipsilateral or contralateral? Is there a difference in the anatomy of the fibular head which would make it more anatomic? And just looking at your radiographs, it looks like the DRUJ is splayed. Is there anything you're doing to reconstruct the distal radial ulnar joint? And I was wondering what your pronation and supination was. And I think one of the benefits of using a free vascularized fibula, even though it's much more arduous, is you get hypertrophy of your graft. So if you did it in older patients where there's a mismatch in size, the fibular grafts that are vascularized tend to hypertrophy and tend to basically become the same size as your bone. Although it's a much more difficult procedure.
Thank you, sir, for your opinion. We have used all non-vascularized graft. We have not used any vascular. We have no facility of microscopy vascularized. The size of the fibula and radius almost same. No bone mimics the radius except fibula. Also, we have taken all ipsilateral fibula and it matches the radius curvature as well as the size of the head of the radius along with the articular cartilage, which make a good arthroplasty if this size of the fibular graft is taken properly and fixed properly.
What about the DRUJ? So the distal radial ulnar joint. How do you reconstruct that?
DRUJ depends on the proper length of the graft actually. If the graft length is more, then also there will be problem. If graft length is less, then also there will be subluxation of the DRUJ. So therefore I told that with the recent techniques of 3D, AI and robotic, all these minor problems will be solved. And it will give good precision perception and result also.
Sir,
Thank you all. Yeah?
I have a question. How to manage the inferior palmar and dorsal ligament of the DURG and TFCC to
Please
avoid
repeat, I did not understand.
the DURG dislocation?
About?
How do you manage? How do you manage the palmar and dorsal radial ligament and TFCC injury to avoid the
So, we have to maintain the anatomy of the distal part of the carpal bones along with the ligaments, and we should properly repair the DURJ as well as the radiocarpal and the fibular head ligament. If the fixation is good, stability is good, then there will not be any problem as far as the joint is concerned. Thank you. Thank you.